For today's pregnancy in hemodialysis patients, and Dr. Ramesh attached to DG Trincomalee. So as we all know, when we talk about the pregnancy in our dialysis population, it is very rare. Right? I'll tell you why in my next slide. And even if the patient gets pregnant, and as you all could think, historically, the outcome was very poor, both from the maternal side and from the fetal side. But fortunately, the advancements in the medical medicine and the hemodialysis alterations have improved the maternal and fetal outcomes. But definitely, this management needs multidisciplinary team approach involving the obstetricians, nephrologists, as well as the dietitians. So now we will look into why this pregnancy is a very rare event when it comes to our hemodialysis population. So when we talk about end-stage kidney disease, so not only the kidney is malfunctioning or not working fine, but there are some hormonal changes that is taking place, which is more irrelevant with the menstruation of the female. So they usually have a low estradiol and decreased clearance of prolactin, both of which usually inhibit the pulsatility of gonadotropin releasing hormone, which is in part, and also the mid-cycle surge of luteinizing hormone are important when it comes to ovulation. So the ovulation is not happening because of these hormonal changes, low estradiol and decreased clearance of prolactin. And even if the ovulation occurs, and because of the changes that happens within the hypothalamic pituitary gonadal axis, there will be an endometrial atrophy. So even if the ovulation occurs, there will be problem with the implantation of the ovum. So approximately 70% of our hemodialysis population, they are oligomenoric or amenorrheic. And in addition to the hormonal abnormalities, 84% of our women on dialysis, they report low sexual functions, sexual activity, which compounds difficulties in conceiving. So even after with these great difficulties, if they do get pregnant, what are the challenges both obstetric team and the nephrologist team is going to face? So there is high risk of hypertension, and as Dr. Nadisha mentioned, there is high risk of preeclampsia. And there are additional complications from both sides, from the fetal side as well as from the maternal side. So what are the fetal complications? They are at high risk of delivering early, leading to preterm birth, and even the growth of the fetus is going to be affected, leading to intrauterine growth restriction. And when we look at the maternal risks, so definitely the renal function would definitely go down, because there is going to be, the kidney is going to work for both the mother and the baby. So definitely there will be worsening, and there will be the renal function related metabolic complications like anemia and electrolyte imbalance could become more severe. And again, the other challenge is going to be from the fluid side, because the volume status of the body is maintained by the kidney. So we are going to face challenges on that aspect as well. And as I have previously mentioned, hemodialysis alterations have improved the outcome. So when we talk about the modifications that need to be addressed during the time of pregnancy, so they say both the frequency and the duration should be increased to 36 hours per week. But I'm afraid in our resource limiting setting in a country like us, it is going to be difficult. But the guideline says at least minimum of 20 hours per week would improve the outcome from both fetal and maternal side. So when we modify these hemodialysis prescriptions, then we need to focus ourselves on fluid balance and electrolyte balance, so that needs to be closely monitored. And we also need to think about the metabolic complications related to this renal abnormality. So anemia, so the hemoglobin need to be closely monitored, and we have to increase the iron supplementation as well as erythropoietin stimulating agents or EPO. And during these alterations, because we are trying to mimic the kidney's natural function artificially, so we need close monitoring of both maternal and fetal well-being. And as I have outlined earlier, so there needs to be a multidisciplinary approach and coordination between nephrologists, obstetricians, and dietitians. So this was a recent trial that was established with the, so they have recommended that 36 hours of dialysis per week was the recommended one, and to keep the blood urea to a minimum level of less than 35 milligram per deciliter. So if we look at the fetal outcomes or the complications that are related from the fetal side, so as I have outlined earlier, so the most common complication is most of the deliveries end up in a preterm delivery, almost 75% of the time. And 30% of the pregnancies end up in IUGR. But with the intensive dialysis, as I have outlined earlier, increasing the frequency as well as the duration of dialysis have improved the neonatal survival rate. So the minimum they recommend from the guidelines, the latest evidence is minimum of 20 hours per week have improved both fetal growth and survival. So when it comes to timing of delivery in our hemodialysis patient with pregnancy, so as I have said earlier, so most of the pregnancies end up with preterm delivery, so we don't have a choice. In that case, the fetus would need a neonatal ICU support. But if they do progress without any complications, the Canadian obstetrician guideline says an elective section closer to 37 weeks of POA would be an option, but it is very, very rare. So when we look at the maternal outcomes and the risks, so they are at high risk of hypertension and preeclampsia, and also the anemia complication might get worse, and it would put a great challenge during the time of pregnancy. So we need to monitor closely. And the next challenge that we face during the time of pregnancy is the fluid overload, because the fetus is going to grow, so that is going to increase the weight of the mother. So we usually plan our ultrafiltration or fluid removal to maintain the volume status of the patient with the interdialytic weight gain. But with the fetal growth, so that is going to put us in a great challenge. So that needs to be closely monitored. But with the dialysis alterations and incremental dialysis, the maternal mortality has reduced, and also the blood pressure control and fluid management has also improved the outcomes of the mother. So if we can summarize the management strategies which has shown benefit, so intensive dialysis is definitely a proven management strategy that has improved both maternal and fetal outcomes, minimum of 20 hours per week, if possible 36 hours per week. That comes to as 6 hours, 6 days a week, and giving a 1 day off for the mother. And the second strategy that has proven benefit is multidisciplinary approach between the nephrologists, obstetricians, and nutritionists. And the third one is what is lacking in our country, is early pregnancy planning, and we need to counsel them pre-conception about the risks and the management strategies that we have, and the outcome is not fruitful. And fourth strategy, we have to monitor the fetal well-being with ultrasounds and the monitoring of their growth. And when it comes to maternal side, we need to monitor the blood pressure very closely and monitor their bloods for the electrolytes and hemoglobin and adjust the medications accordingly. So this was the only patient that I have come across who was a dialysis patient, and she was only 34-year-old, and she was getting routine dialysis, and she was discovered to be pregnant at 8 weeks of gestation. So the dialysis was increased to 24 hours per week, and during the time of her pregnancy, the blood pressure was found to be very challenging, and it needed optimization of the antihypertensives. But fortunately, or unfortunately, she delivered around 32 weeks due to preeclampsia, and baby was admitted to neonatal ICU. But both mother and child discharged after 4 weeks of close monitoring. So that was a good outcome, but she had a complication with preeclampsia. So this would be my take-home message, the recommendation. So if we start from the beginning, that the patient needs preconception counseling, and if the mother gets pregnant, we need to modify the dialysis to be more intensive, as we have outlined, and then involve the multidisciplinary team in the management. And during the pregnancy, with the multidisciplinary team approach, we need to monitor both maternal and fetal side. And even after the delivery, we need to be closely monitoring the mother, because we need to put her back to her regular dialysis schedule. So again, that monitoring should go on even after the delivery. So these were the guidelines that I have referred. So the intensification of dialysis was emphasized in KDIGO guideline, and again European Renal Association guideline and ASN, American Society of Nephrology guidelines. So they all recommend 36 hours of dialysis for a week. And then second strategy of fluid and blood pressure management was also emphasized in KDIGO and European Renal Association and American Society of Nephrology suggested, but they have recommended that the careful volume control is needed so that the placental perfusion is not compromised, so that the fetus is not experiencing any hypovolemia leading to IUGR. Then the third strategy, anemia and mineral-borne disease management. So this needs close monitoring. Again, the same guidelines have emphasized, and the multidisciplinary team approach also, all guidelines are recommending that, and nutritional support is also an important part. So these were the references and the trial evidence that recommend these strategies. So that's all I have to say about pregnancy in a hemodialysis patient. Thank you.